All right, a very warm welcome to your renal posting here at Ktph. This is the first chapter of your survival guide, and we're jumping right in to tackle a big one, chronic kidney disease. We're going to focus on exactly what you need to know for that first time you see a CKD patient on your list. Let's get into it. So, picture this. You're on call, you're scrolling through the blood results, and you see that all too familiar trend. A patient's serum creatinine is climbing. This is probably one of the most common problems you're going to face. But it's so much more than just a number on a screen, right? It's a signal that we need to build a complete clinical picture, and we need to do it fast. So, where do we even begin? Let's make this real. Let's talk about Mr. Tan. He's 62, and he's got the classic risk factors we see all the time in Singapore: diabetes and hypertension. Honestly, he could be any patient you see in the clinic or on the wards today. For the next few minutes, Mr. Tan is your patient, and we're going to figure out his story together. All right, first things first, the workup. To really get a handle on what's going on with Mr. Tan, we need two fundamental pieces of data. These two numbers are going to guide our entire management plan. First up is the eGFR, or estimated glomerular filtration rate. The easiest way to think about this, it's the kidney's speedometer. It's calculated from that serum creatinine we saw earlier, and it tells us, very simply, how well the kidneys are doing their main job of filtering waste out of the blood. It's our core measure of function, plain and simple. The second piece of the puzzle is the UACR, the urine albumin to creatinine ratio. Now, if the eGFR is our speedometer, think of the UACR as our leak detector. It's measuring a protein called albumin in the urine, which tells us directly if there's damage to the kidney's filter. And crucially, this is a really big deal. It's also a powerful predictor of the patient's future risk of heart attacks and strokes. So how do we put those two numbers together? This is where it gets really cool. This is the KDIGO 2024 heat map. I want you to forget just looking at the GFR stage in isolation. That's kind of old school. This grid combines the GFR on one side with the albuminaria, or UACR, on the other. And just like that, it gives you this powerful at-a-glance visual of the patient's prognosis. Green means low risk, but as you move down and to the right into the yellow, orange, and red, that risk gets much, much higher. Okay, let's get back to Mr. Tam. The results are in. His eGFR is 40 and his UACR is 150. So where does that put him on our map? We plot it out and boom, he lands squarely in that red zone. This tells us instantly that Mr. Tan is at high risk, not just for his kidney disease getting worse, but for cardiovascular problems too. It's a perfect example of why you need both numbers to really understand the risk. So we've staged Mr. Tan, and we know he's high risk. The big question is, now what? What do we actually do about it? This is where we shift gears and start crafting an actionable blueprint to manage his condition, both for today and for the long haul. Let's start with the immediate stuff, your day one checklist. First, review that creatinine trend. Is this a new problem or has it been creeping up for a while? Step 2, and this is huge, a thorough medication review. You're hunting for the usual suspects: NSAIDs, traditional medicines, even things like PPIs. Then, get a full urinalysis, do a solid clinical assessment of his volume status and blood pressure, and finally, consider a trial of hydration, and most importantly, stop any drugs that could be harming the kidneys. Okay, that was the immediate plan. Now for the long game. These are the pillars of modern CKD management. We're talking about tight blood pressure control, excellent glycemic control, and then using our key protective medications, the RAS inhibitors and the SGLT2 inhibitors. Add in lifestyle changes and a strict lifelong avoidance of anything toxic to the kidneys, and that's our foundation. Now, despite our best efforts, Mr. Tan's GFR might continue to decline over time. And when that happens, a new set of challenges pops up. Your role starts to shift a little bit, from primarily slowing progression to also actively managing the common complications of more advanced CKD. There is one number I really want you to burn into your brain: 30. 30 ml per minute. Once a patient's eGFR drops below 30, it's a critical threshold. At this point, you have to switch into a proactive mode, screening for the major complications of CKD. Because trust me, they will almost certainly start to appear. So what are we looking for? Well, the two big ones you'll manage over and over are anemia and CKD mineral and bone disorder, or MBD. Anemia happens because the failing kidneys just don't make enough of a hormone called EPO. Your job is to check their iron stores and think about starting them on an ESA. On the flip side, MBD is all driven by phosphate building up, which throws calcium and parathyroid hormone out of whack. Here, Your job is to be a hawk on those labs, monitoring them closely. Eventually, for many patients like Mr. Tan, there comes a point where medical management just isn't enough anymore to control their symptoms. And it's so important to frame this correctly. This isn't a failure. It's the expected next step. This is our cue to begin that crucial, sensitive conversation about renal replacement therapy, whether that's dialysis or transplantation, and planning for the next chapter in their journey. Okay, wow. That was a whirlwind, right? From the initial workup all the way to advanced complications. So let's boil it all down. What are the absolute must-know core principles you need to take with you to the wards today? Here they are, your 4 take-home messages. Number 1, stage every single patient using both eGFR and UACR on that heat map. It tells you the prognosis. Number 2, control the controllables. Be relentless about blood pressure, glucose, and proteinuria. 3, protect with pills, prevent with pauses. Use those great RAS and SGLT2 inhibitors, and always pause potentially toxic drugs. And 4, anticipate. Once that GFR drops below 30, you start actively hunting for anemia and MBD. So there you have it. That's your rapid-fire guide to your first encounters with CKD. Keep these principles in mind, and you're going to be in great shape to provide excellent care for your patients. Once again, welcome to the team. We're really glad to have you.